Good evening. I am Majid Elbalony. I recently passed FRCS Trauma and Orthopedics International. It was held in Dubai a few weeks ago. I passed from first attempt, part B. I think I passed this exam because of following Orthopedic Academy YouTube channel. I appreciate the great work done by the Dr. Firas Arnaout and Dr. Shuan Henry and their team. So I am so happy to join them and to help them to share my experience in this exam. I prefer to start with Viva table, trauma. First of all, I'd like to disclose that I took some pictures and X-rays from lectures of Orthopedic Trauma Association available on their website. First of all, Viva exam of FRCS. They are 4 tables. Trauma is one of them. Each table, 2 examiners. Each examiner will ask you 3 questions, and the other one will listen. And the other examiner will ask the other 3 questions, and the other one will listen. But both of them, they will give you the grade out of 8. Each table, 6 pictures with X-ray or clinical photo. Each station 5 minutes. You will shift to next station after you hear the bell. Total table 30 minutes. My advice is to keep sticky to basic science, anatomy, deforming forces for each fracture, and principles of fixation. He will not ask about details of surgery, but he like to listen to principles of fixation. Keep systematic, well organized, self-confident. My advice also is to answer as if you are in your hospital. I answered all trauma questions as I am in emergency in my clinic in OR. Here I will present a few cases. I will explain how to answer in the question. This is not a lecture. This is only a presentation how the exam is going. First case is this clinical radiograph. This radiograph of AB pelvis. Describe X-ray. You should describe the X-ray. This is plain radiograph showing of skeletally mature patient, showing fracture of left ilium, fracture of superior and inferior pelvic rami. There is symphysial diastasis. How to classify this fracture? We are classifying according to Young and Burgess. What investigation also you should do is CT scan. How to manage this patient? Mostly it is polytraumatized or road traffic accident. So we will apply ATLS protocol. This CT scan shows the fracture. There is no sacroiliac dislocation by itself, but it is a fracture dislocation. So it is called crescent fracture. You want to hear the word crescent fracture. This is a classification. He may ask about details of the classification. You should be aware of it. This is lateral compression to crescent fracture. I want also to say, don't say ATLS protocol in each case. This will irritate the examiner. The examiner want to hear ATLS in the proper scenario, like fracture pelvis, like fracture dislocation spine, like acetabular fracture, like bilateral femur fracture, like this. This you expect this is polytraumatized patient. But if you say this is ankle fracture and ATLS, he will get mad of you. This is another case, a plain X-ray radiograph, plain X-ray of skeletal mature patient showing symphyseal diastasis with sacroiliac also widening. So how to classify? I can classify as ABC3, pubic diastasis more than 5 centimeter, anterior and posterior sacroiliac diastasis. Also, you will answer applying ATLS protocol. Rarely he will ask about details of ATLS protocol, but he will jump to the question, what you will do for this pelvic fracture as first aid or in emergency. You will say, I will apply pelvic binder. How to apply pelvic binder? What are the mistakes in pelvic binder application? What is the benefit of pelvic binder application? Pelvic binder should, we are using sheet or something like that to compress the fracture, to close the pelvis, to help clot formation, to make the patient more stable. So we are putting the binder centered over greater trochanter. This is the key for the answer. What is the maximum time you can allow this pelvic binder to be applied? I think 24 hours. After that, if you need the pelvic binder, you will shift to external fixator. He may ask about how to apply external fixator. What is the landmark for external fixator? The Shan's sites. Where you will apply the Shan's, supraacetabular or in iliac crest. What is the pros and cons of each method? You should be aware of that. Case number 3. This is a very, very common case. Very common case scenario. This patient is young adult with transcervical fracture neck of femur. So describe X-ray. Okay, this is plain X-ray of right hip showing of skeletally mature patient showing displaced fracture, transcervical femoral neck fracture. Options of treatment, factors affecting outcome. This patient, because he is young adult, so we will plan for surgical fixation, not arthroplasty. The questions here are different. Many questions, very common questions. You may be asked all these questions. How urgent are femoral neck fracture in young? Yes, it is urgent, but not emergency. Urgent means you will do within 24 hours, within 12 hours, if it can. He will ask you, this fracture came to you at 10 p.m. Okay, you will fix over the night? No, I prefer to fix in the following day orthopedic list. So, why? Because it is urgent, not emergent. I can do within 24 hours, but I'd like to do proper fixation. I can ask for help from my colleagues. I will be working with experienced staff working with orthopedics. Is there a difference in outcome between open reduction and closed reduction? In the last 10 years, there is tendency toward open reduction rather than closed reduction. So the priority is for anatomical reduction. If you say open reduction, okay, the next question will be, what approach you will use? You will use single approach or double approach? Usually the answer is double approach. You will use anterior approach for the neck reduction and fixation if you use blade for the neck femur, and lateral approach for DHS or cannulated screws. What is the best implant? We have many methods to fix this fracture. We have cannulated screws. We have DHS and the anti-rotational screw. We have also buttress plate in addition to cannulated screws, or combination of all of this. What are the complications? Complications, the many complications, but for the orthopedic complication, it will be non-union, malunion, and avascular necrosis, and how to deal with each complication. So, factors affecting outcome: first, anatomical reduction; two, time of fixation. It is a surgical urgency, not emergency. Accuracy of reduction is more important than time to surgery. You want to hear that. Earlier, generally better. Goal within 12 to 24 hours. Also, age is affecting. So young adult can heal. Old age or comorbidities, difficult to heal. In this X-ray, you can see the two methods of fixation are added, double fixation, but because the goal is anatomical reduction. Definitive management, open reduction, internal fixation. This is methods of fixation: sliding hip screw, plus or minus anti-rotational screw, cancellous screws, blade, modern plating system, as you see in previous slide. Open versus closed. We prefer if it reduced closed, it's okay. If you are successful to get anatomical reduction by closed methods, it's okay. But if you fail to get anatomical reduction in AB and lateral and oblique, you should do open reduction. What is the approach? Anterior approach of the hip, Smith-Patterson. He may ask about details of that if there is time. And lateral approach, what is the position in supine position? Sometimes we are using single approach for reduction and fixation, anterolateral approach of the Watson-Jones. But the first answer is preferred. Open or closed, I said in last 10 to 20 years, there is tendency toward open reduction. Anatomical reduction, closed or open, and stable internal fixation gives the patient the best opportunity to avoid complication. In your reduction, avoid varus, avoid posterior tear. This is sliding hip screw and anti-rotational screw. This is sliding hip screw and medial buttress. This is isolated cannulated screws using closed reduction, and it is reduced well and it healed well. In cannulated screw, we are using 3 screws in inverted triangle model. Inferior screw within 3 millimeters of calcar. Posterior screw within 3 millimeters of cortex. Threads more than 5 millimeters from subchondral bone. There is debate about using partially threaded or fully threaded. Fully threaded will prevent collapse, but will not help compression. Partially threaded will help compression, but it can cause collapse. Also, the screws shouldn't be beyond lesser trochanter to avoid the stress riser. Also, the screws entry shouldn't be close to each other, not to make single hole. This is a common case. You describe X-ray. This is plain radiograph showing fracture neck of femur in skeletal mature patient. If you jump to management, you will fail this slide because he will let you to see this one. If you say, okay, I will do open reduction, internal fixation, trial of closed reduction and cannulated screws, or the sliding hip screw and the interrotational screw, it's okay, you are excellent. But if he let you to see this slide for the same patient, you will withdraw all what you said because the management is different. So this patient, you should ask about this patient is polytraumatized or not, is it stable or not? Because if the patient is vitally unstable, if Glasgow Coma scale 5 or 4, you will manage as damage control orthopedic. How to manage this one as damage control orthopedic? Damage control orthopedic for fracture neck femur is open reduction and internal fixation. For just shaft femur, you can do external fixator only. But for fracture neck femur in damage control orthopedic, you should do open reduction, internal fixation. So when you see this, when the examiner present this X-ray, you should ask for full length X-ray. Ask him, I need full length X-ray femur, because this is a tricky question in FRCS, very common. So if the patient, okay, the patient is stable, is a patient no need for damage control orthopedic. What is the definitive treatment? Definitive treatment is 2 methods of fixation. I will fix fracture neck femur by DHS or sliding hip screw and the interrotational screw, either closed or open, and retrograde nail for fracture shaft femur. Also, you can strengthen your answer by 5 to 10% of femoral shaft fracture are associated with fracture neck of femur. Frequently, vertical neck fracture missed in up to 30% of cases. If there is doubt, you can do MRI. So this is a method of double fixation of fracture neck femur and shaft femur. Which one you will start with? Fracture neck femur or shaft femur retrograde nail? If the fracture neck femur is undisplaced, you can start by fixing it and do retrograde nail femur. But if it is already displaced, so no fear of more displacement, you can start by retrograde nail femur and end with fixation of the neck femur. What about the complication? Complication, one of the complication you will say non-union or delayed union. How you manage this one? The common answer is valgus intertrochanteric osteotomy. Why? To convert vertical shear forces into compressive forces. This is, and bone graft. This is a trial to save the head of femur before it goes into non-union, then collapse and vascular necrosis and collapse. This is also fracture neck femur in adult, but 72 years old. And the patient also has multiple comorbidities. You should ask about comorbidities of the patient. How is the patient activity? What is the walking distance before this fracture? But don't ask too much about that, because he is pushing you toward arthroplasty for this patient. So in this age and this quality of bone, he will talk about arthroplasty. But the discussion will be what type of arthroplasty, hemi-arthroplasty or total hip arthroplasty. If the patient has already osteoarthritis of the hip, okay, we will proceed without discussion about total hip arthroplasty. But if no arthritis and the patient needs is low demand, and the patient is advanced age, like 80, So we prefer cemented hemiarthroplasty. But if the patient is active, he used to run, to walk 2 kilometers per day. So we can do total hip arthroplasty. He will ask about door classification. Door classification to choose which type of arthroplasty, cemented or cementless. What is the pros and cons of each one? This is important. Arthroplasty, we are considering in patient with advanced age, non-reconstructable or extensively comminuted fracture neck of femur. Also in patient with high risk of re-operation. Patient, we think the fracture neck femur will not heal, so we proceed to arthroplasty. Patient with renal disease, difficult to heal, liver disease, respiratory disease, all of them we are we have tendency to do arthroplasty rather than open reduction internal fixation. Like this patient. This patient has atherosclerosis. You can see the artery here. So we put hemiarthroplasty, cementless arthroplasty, hemiarthroplasty for this patient. Okay, now I will stop at this slide. Next time I will complete the trauma of lower limb. Then we will do another lecture for upper limb, another lecture for pediatric, also a separate lecture for spine. I'd like to thank Dr. Faraz Arnaout again and his team in Orthopaedic Academy YouTube channel. They are making great efforts. We owe our success and passing the FRCS Part B exam for them. Also, I'd like to appreciate the great work in the book of concise orthopedic notes. It is very simple, very concise, but very comprehensive. I used to study from orthopedic concise notes. I think 6 months or more before the exam. I can study it many times for the exam because it is time saving, highly cost effective, and very, very efficient. Thanks to them and thank you all, and hope to see you in next lecture. Thank you.